Hello, everyone. Good afternoon. Welcome. Thank you for joining us for today's webinar. My name is Karen Bell, and I'm an Associate Director for the Partners for Advancing Health Equity, or the P4HE Collaborative, which is a national research learning collaborative based at the Tulane School of Public Health and Tropical Medicine and sponsored by the Robert Wood Johnson Foundation. At P4HE, our aim is to bring together the various sectors that are working on health equity, including government, academia, community-based organizations, philanthropy, and the private sector. We convene these sectors to work together to better understand critical issues related to attaining health equity. We do this in part by providing spaces for activities to engage with these groups in insightful conversations on timely topics and to promote actionable solutions. So today we're going to talk about a set of issues related to population mobility that are central features of health equity. We will begin the webinar by reviewing general relations between immigration and health by our moderator, Mark Van Landingham. After that, we'll bring in our panelists to talk about some of the health problems that immigrants face and challenges they face in addressing these health problems. The webinar will focus specifically on the United States. While other migrant destinations will share some of the challenges we'll talk about today, there are other ways they will be quite distinct. I think it's really important for us to have this topic as part of our webinar series. And so we're going to talk about, or I'm going to talk about who our panelists are. First, we have Dr. Mark Dalcorso. He's an associate professor here in the Department of Social, Behavioral, and Population Sciences at Tulane. We have Lara Ho, Chief Operating Officer for DuPont Clinic, Jeremy Zhong, Staff Attorney for Untreated, Olga Ocampo, Community Health Navigator 2 for DePaul Community Health Centers, and Diem Nguyen, Chief Executive Officer, of Noella Community Health Center. So with that introduction, I would like to pass the podium to our moderator, who will contextualize and frame today's conversation even more. Dr. Mark J. Van Landingham is professor and director of the Center for Studies of Displaced Populations here at Tulane. Thank you for joining us, and welcome, Mark.
Thanks, Karen. Hey, everybody. Thanks for joining us, on this webinar focusing on immigration and health. I'm Mark Van Landingham, and I'm going to be moderating this. And part of my duties is to provide a framing or an overview of the topic. So here goes. Let me share my screen. Okay, I'm going to start by answering a question that some of you are probably asking. Why is this guy the guy giving this overview? It's a fair question. Then I'm going to go right into the overview and talk about why immigration and health might be of interest to people in public health and elsewhere. Talk about a few causal mechanisms that are proposed and evaluated in the research literature, give a few takeaways, and then I'll transition to the next section by asking ourselves, so what? Okay, on the says who part, as an academic, I've done a lot of research on the topic over several decades, give a few overviews that I've been involved in on the topic on the very last slide. Each year, I also teach a graduate course on the topic, and so this requires me to synthesize and be able to communicate a lot of complicated information about a really vast and complex field, and also forces me to keep up to date, so the students don't catch me flat-footed. And then, personally, I've lived abroad myself for 3 extended periods, once in Thailand and another time in Bangladesh, and then also in Vietnam. So I've had a little bit of personal experience about what immigrants go through when they're kind of navigating a new context and everything, but especially with regard to healthcare. Okay, so on the on the framing of the issue, why might public health practitioners and researchers be interested in immigration and health? Well, there are lots of reasons. Here are a few. One is that immigrants are going to have a very different health profile from the existing population at the place where they end up. And mostly we're talking about the United States here. They're going to be different from people who didn't migrate, from origin too, but I'll talk about a bit more about that in a moment. But from the perspective of people who are working in the U.S. and are interested in immigrants and maybe delivering healthcare and other services, we're really interested in immigrants because they're going to change the overall profile, and they're going to come with a few new problems that maybe some of us who are working in healthcare would not have been so familiar with beforehand. Some of these differences are going to be vulnerabilities. There's also a lot written in the literature about advantages that a lot of immigrants have with respect to the sending population and also a destination. I'll talk a little bit about that, near the end. In terms of the proposed causal mechanisms, well, it can be pretty complicated, partly because the arrows can go either way. First of all, health is going to affect the propensity to migrate. So people who end up deciding to leave where they were are going to be very different from people who decide to stay put. And one set of differences is going to be overall health status. Migration is generally not for the frail. It's very difficult, both the picking up and leaving a place that you're familiar with. The journey is often hard, and then also settling in is also quite difficult. Other ways in which migrants might differ from non-migrants, even before they go, have to do with personality and mental health. As I noted on the last slide, and again with this first bullet, migration is not for the frail. Well, the point of the second bullet is that it's not for the timid either. Migration is not only difficult, but it's also risky. And so risk-averse individuals typically do not decide to migrate. They're much more likely to stay put. So my overall takeaway, on this that I very subtly indicate with the 3 stars is migration is not a randomly occurring event. This is important because I think a lot of people will kind of generalize characteristics of migrants from, say, Mexico or China or India, and think that they're very typical or characteristic of the places that they came from. And in some ways that's true, but in a lot of ways it's not true, because migrants are very special people. And that's what I mean by selection. So health can affect migration, but it also works the other way. Migration can also affect health, and this is typically what we're interested in, in public health and in other areas, where we're interested in immigrants. So, how does the immigration process affect the health of immigrants, and how might it result in better or worse health? And the answer is that it could be either. And in fact, in many cases, it is either. On the positive side, pretty obviously, if a migrant comes over and they're realizing their hopes and dreams and things go well, they will often become much more better off financially than they were at origin. So more money is going to allow you to kind of have a cleaner, safer, more healthy environment, buy better food. Quite, pretty obvious. Kind of a more subtle way that's often a surprise to people is that the environment in the United States compared to the environment, especially the home environments where a lot of immigrants are coming from, is much cleaner, especially with regard to the indoor air. Many places in low and middle income countries will use coal or wood for heating and cooking. So often the house is filled with smoke, which has a really negative impact on children in particular. So often coming to the U.S., results in a cleaner environment, but there are also negative effects. That things don't always work out well. For people who come to the U.S. or other places, and so many people will end up poor. And the U.S. is a very difficult place to be in if one is poor. More subtly than that, the stress of kind of not knowing what to do, breaking your familiar routines, encountering bigotry, these sorts of things will wear on an immigrant over time. And stress is a lot of really good recent research is showing that the accumulation of stress over time has really negative impacts on health. So the third point I'd like to make regarding the causal relations between immigration and health is that there are kind of lots of different places where these effects might take place. The effects of deciding to move on health might occur even before the person leaves, at origin, along the way, or at destination. So this framework, it kind of diagrams this, and just kind of work through a few examples. Sometimes at origin, especially if society is under siege or under distress, there's going to be a lot of social breakdown, violence, perhaps, and it's going to kind of result in a lot of health challenges, trauma, and other things that an immigrant who's leaving might take with him or her once they finally get to destination. Along the way, they may also face health challenges by, say, being harassed or worse, by soldiers or police and other officials, especially if they're undocumented, being exposed to the elements and things like that. And then finally, once they get to where they're going to face health challenges, say, while they're trying to get health care for their kids and family and things like that. The fourth kind of main point that I want to make regarding this relationship between immigration and health with regard to causality is that it's difficult to discern causality because health status is going to co-vary with a lot of other things that are related to migration. Typically young adults, it's typically people with pretty good connections at destination and some good social support systems. I've talked about physical health and risk tolerance, those sorts of things. So the fact that there's lots of things going on at the same time will make it hard to figure out what effect the actual move the immigration has, on the health status. So lots of things going on, and that's really the point of the fifth bullet too, is that migration doesn't occur in a vacuum, but rather it's going to be happening within very complicated and dynamic social, economic, and historical context. So with all these things going on, it can be helpful sometimes to sketch out a diagram of what we think is going on, in this case, with regards to how immigration might affect health. So this model was developed by my former doctoral student, Hong Fu, for her dissertation, which was focused on immigration and health. And Hong Yun concluded in the end that migration from Vietnam, among those who left Vietnam, did have a large number of very complex set of effects on the health of those who left and came to America, both on physical health and mental health. But that's a complicated story for another day. What I wanted to show here is that there are lots of it's longitudinal. There's one thing leads to another, and it can be fairly complex to kind of figure out how much of it was really due to migration as opposed to some of the other things that I mentioned. Okay, I'm going to wrap up with just a few takeaways. First one is that the relationship between immigration and health are complex. The second one is that we as public health practitioners or clinicians or scholars often focus on the negative consequences of immigration on health, but most immigrants actually fare quite well at destination. In fact, there's a big literature on how a lot of immigrants who come over do much better than multi-generational Americans, so people who've been here for a long time with similar characteristics. So a lot of immigrants actually do really, really well. With that said, many immigrants, especially refugees, are highly vulnerable to a wide range of negative health outcomes. In terms of the so what, well, you're in luck. We put together this terrific panel of people who are actually working in the field, providing services to real live immigrants. They're not academics like I am. And they're going to have a lot to say about what they're seeing in their communities. Final slide is just a couple of overviews in case you're interested. And this is a book I've recently written about the Vietnamese immigrant community in New Orleans. Okay, so I think we're going to jump right into the panel discussion. And thanks so much, to all of my colleagues, who are taking time out of their busy day to join us today. So, I think I'll start with you. So. I'm going to ask everybody this question, but maybe Ian, you can kind of start it off. Tell us a little bit about the work that you're doing related to immigrant health. What do you and your colleagues do? How long have you been doing it? And then tell us a little bit about the immigrant communities that you're working with. Ian?
Hi, good afternoon, everyone. And I'd like to thank Mark, Oma, and Karen for having me here today. So just a little bit about Noella Community Health Center, where I work. We officially opened our doors as a federally qualified health center, or an FQHC, in 2014. But we have been providing healthcare services in partnership with Tulane University School of Medicine and also Children's Hospital since 2008, right after Hurricane Katrina. As some of you may also know, an FQHC is a community-based healthcare facility that provides primary care services in underserved areas. In addition to providing primary care services, Noella also provides specialty care services such as allergy, OBGYN, behavioral health services, and physical therapy that we opened up, I'm going to say about 2 years ago.
That's perfect. Thank you. So we're really lucky on the panel that we have Yim, who's the executive director overseeing this clinic that's serving a lot of, both Vietnamese and Latino immigrants. And we also have a couple of practitioners, working in a different clinic. Mark and Olga, tell us a little bit about your clinic and some of the work you're doing there with your immigrant patients.
Okay, I'll start briefly and then pass over to Olga. My name is Mark Del Corso. I thank you all for listening to this also today. And as Mark mentioned, I had lived about 5 years in Mexico and 5 years in Central America. My wife is from Mexico. And so when I started working after my Tulane training in community health centers in New Orleans before Katrina, I would see maybe one Spanish-speaking patient a month or per year, and now I see one every 15 minutes because of the changes after Katrina in New Orleans and just the recent influx of large numbers of recent immigrants. And I'm a pediatrician, and as Dia mentioned, community health centers are really a strong point in the U.S. system. In 2021, they served about 30 million patients nationwide. And I know if a Spanish-speaking patient walks into our office, they have Spanish-speaking receptionists. There's medical assistants that speak Spanish and many of the providers, and then we have translation services. And we do have a sliding scale for them as far as their payment goes. And we also have what's called a 403B pharmacy, which is subsidized, so they're able to get medications at lower cost. But Olga works very closely in helping, especially a lot of our prenatal patients. So I'm going to pass over to Olga and see what she'd like to share.
Good afternoon. Thank you for having me. It is a pleasure to be here with you all. So my name is Olga Ocampo, and I am one of the community health navigators here at DePaul. And like Dr. Del Corso said, I work closely with the Hispanic community. I strictly work with the Hispanic community and also our prenatals patients. And pretty much what I do is if a patient is in need of any resources from housing to attorneys to WIC applications, anything that the patient may need and they're not able to do it due to the language barriers, basically that's what I do. Just guide the patient through the motion and, everything that they need as far as the resources.
Thank you, Olga. Jeremy, tell us a bit about the legal services that you and your colleagues are helping immigrants with.
Right. So my name is Jeremy Zhong. I'm a staff attorney with El Otro Lado. I primarily work with people who are in immigration detention centers in Louisiana. So people who, for various reasons, have been arrested by immigration and are either awaiting their deportations or are fighting to stay in this country while in, Wynn Parish or Rapides Parish or LaSalle Parish, right? And so that's kind of my small slice. I have colleagues as well. I think that who are involved in a legal medical partnership in Tijuana on the border, who are seeking to provide medical care for folks who are kind of awaiting their opportunity to apply for asylum in the U.S.
Thanks, Jeremy. So Lara, you worked for many years for the International Rescue Committee, focusing a lot on refugees, and you've recently taken a new position at the DuPont Clinic, which might also provide some services to immigrants too. Tell us a little bit about the work you and your colleagues are doing.
Sure, yeah. So here at the DuPont Clinic, we're an all-trimester abortion clinic, and because of the various laws that have come into effect in many states, we're seeing about 2/3 of our patients come from outside the DC area. I'm based in Washington, DC. And we also have people coming from outside of the country to seek care. We certainly have immigrants. Today in clinic, we have 2 patients who don't speak English. They're both Spanish speaking. And so we have staff who are bilingual who are able to support them. And it's quite a challenge for people who are having to travel, particularly if you're needing to come from Texas to Washington, DC, and you're undocumented, it might be quite difficult for you to get on a plane and get access to care that you need. So although we don't focus specifically on immigrant health issues, we certainly see a lot of immigrants among our clients, in part because often people have poor access to care and they're not able to get services earlier in their pregnancy. And so they need to come to us when they're in their second or third trimester because they haven't had access to the service they need, or they're not available in their state. In my previous work at International Rescue Committee, I worked on the international side, but IRC also works on refugee resettlement. So they have programs that are supporting not only refugees, they also work with various immigrants throughout the United States. My focus was really on people who were displaced mostly by or affected by conflict in various parts of the world. So working both in refugee camps, with internally displaced people, with populations who were receiving refugees or displaced people and affected by conflict there. I work specifically in public health, but our organization works both on things like protection, legal services, education, governance issues, and other needs that people have when they're displaced by conflict or other crises.
Thanks, Laura. So my first question is actually about acute crises or emergencies, and both of your work with IRC and with the DuPont Clinic makes you really well positioned to address this. So tell us a little bit about the work of your colleagues with acute crises or emergencies, and then I'll ask later about kind of more chronic and long-term immigrant health issues.
Sure. So with IRC's mission really was to support people who have been affected by conflict or crisis to recover, thrive, and rebuild their lives. And that means that IRC responds to nearly every major conflict-related crisis in the world. So, for instance, when the crisis in Ukraine broke out, we had teams going there working. I've worked both in the Middle East around the Syrian conflict, many countries in sub-Saharan Africa, Yemen. We've also responded to the Venezuelan crisis. So we have programs now in South America, also in Central America, dealing with some of the violence that's happening in places like El Salvador, and pretty much any major crisis that happened. I responded to the Ebola crisis in West Africa and was there for some time. In the US now with my current work, I think you could say we are having a crisis with access to abortion care in the US, given all the changes that have happened since Dobbs. And we've absolutely seen that there are more and more people who need support to access abortion care. We used to have a lot of more patients who paid out of pocket, but given financial crises and the fact that people have to travel further to get care, more and more of our patients are being supported by local abortion funds or other donations because they're just not able to afford the costs of being able to take time off work, to have to travel, and to pay the costs for healthcare.
Thanks, Laura. Jeremy, I bet you've seen a fair number of health crises among your clients. Could you tell us about maybe a couple of common scenarios, and then what kind of options are available for alleviating these kinds of health crises for the immigrants you work with?
Sure, yeah. So as I said, I deal mostly with the detained population. So the vast majority of these people are folks who are seeking asylum in the U.S., right? So the vast majority of people, something really terrible has happened to them in their home country, someone that they know has died, or something of that nature. There's also, so there's definitely a lot of trauma, a lot of mental health issues. The the other big issue that you see is that like oftentimes the trip to the US is very harrowing. I mean, because the US really engages in a policy of trying to extend its borders as far as possible. So the U.S. works with the Mexican government, with the Guatemalan government, with the Honduran government, with the Salvadoran government to try to slow and stop the flow of migrants up, right? And so what is happening is that like folks are being pushed further and further and further south. So if you are someone trying to seek asylum from, I mean, you see it, right? Like we see it all the time from Ukraine, from Russia, from pretty much all of Africa. What you're doing is you're flying to Brazil, and you are walking all the way up to reach the border, right? And so a lot of terrible things happen along the way. You have to go through the Darien Gap, where it's just like jungle. There's a lot of kind of like extortion and kidnapping along the way, and they get to the border, and the U.S. border is closed for the most part, and so there's no mechanism for most people to actually apply for asylum. So what you're stuck with then is you're stuck in some sort of shelter on the U.S. border, and for months or years at a time, and people are very vulnerable in these shelters. A lot of stuff happens to them there. So a lot of mental health issues. Once people are detained, what we see actually is a lot of gastrointestinal issues. Everyone complains about their stomachs, about various
Stress, right?
Say again?
Probably a nod to stress and just the kind of accumulation of not knowing what's going to happen and kind of being off your routine.
Yeah, I mean that, and like you have private prison companies who are very incentivized to keep food costs down, right? One of the guards there told me that he tried to feed the food to his dog, and then his dog wouldn't eat it. So yeah, it's the stress combined with like actual like not nutritious food.
Yeah.
So yeah, mental health, gastrointestinal, I think are the kind of biggest issues.
Yeah, very grim picture for people who are trekking all that way trying to get into the U.S. What about for the people who are already here? So Mark, Olga, what are you seeing in your clinics? In terms of kind of acute crises, anything typical or generalizable?
Yes, I would say that most of the patients that we treat here in a clinic, I would say 98% of them have mental issues. The thing with the mental issues, even though we may offer them the mental health and counselors, for whatever reason, within the Hispanic community, the stigma of depression, a lot of people don't speak about depression. Or maybe they don't know what depression is or what depression feels like. So they just kind of want to rub it off and just, pretend it's not there. However, to me, the depression amongst the community that we see here at DePaul, I would say depression is a big one.
I saw Guillaume nodding your head a couple of times. Guillaume, you've seen some similar things?
Definitely. I feel like the Latino population and the Vietnamese population, we have a lot in common in that sense, is that mental health is a stigma. We see a lot of it here. But I think the problem really is where do we find competent providers who speak the language, right? Because you can have an interpreter, but that's really not the same thing when you're sitting in a room and somebody needs mental health counseling for an hour. We can have interpreters that are in there for maybe 15, 20 minutes, and then they get gassed out because it gets really tiresome. And then emotionally, when they're listening to all of this, they are very emotional and they can't stay in the room any longer than 15 minutes. And so, it's really hard to just find, providers that are bilingual in this community as well. So, yeah.
Yeah, and providers that are able to do it at a reasonable price.
Well, I mean, at an FQHC, like for us, our services for mental health, it's not our, our nominal 35, it's actually $5 to $10, for a session. And so the session may last from 15 minutes to an hour at $10, but sustainably, financially, how do you sustain, an organization that, that does that? So for us, it's hard.
Mark,
But
how about,
but we work it out,
sorry, Mark, how about kind of longer term untreated chronic health issues? I realize mental health, it will sometimes fit into that as well. But anything else that you're seeing in terms of stuff that's really been neglected and hasn't been taken care of for a long time among some of the immigrants that you're seeing?
So, I mean, before I even heard all this, the first thing that came to my mind was mental health and adolescence. And sometimes we will refer them. And I've had like one girl, when I called the mom to see if she was getting the follow-up at Children's, she just said, no, the dad decided to take her to California, thought she might do better over there because they're very mobile and that kind of thing. So getting them into mental health services is difficult. With other chronic conditions, and I mean, fortunately, kids are pretty healthy, but things like asthma, behavioral disorders, ADHD, things like that, where they need repeated visits, especially if they're uninsured. It's a barrier for them because they do need to come in and for each of those services, which they might try to avoid. And if we need to refer them, say, to Children's Hospital, Children's does have an assistance program that they can apply for, and I actually have a student working on that right now to kind of assist with that because they do need documentation in order to get into some of those assistance programs for chronic care.
How about among the Vietnamese? Any kind of long-term chronic issues that are being neglected in that community that you could generalize about?
So I think for us, diabetes, a lot of the diabetes, cholesterol, just the common things that you see, and I think in any society, right? I think for us, the men, I don't know what it is with men, they just don't want to come to clinics. And so those kinds of things. And so those kinds of things are really hard to maintain, right? Is that your diabetes, like Dr. Mark said, right? Those need to be maintained and they have to come every 6 months, or hypertension, they have to come. And so they just, a lot of them just don't. And I don't know what it is. We try to educate them in the exam rooms, but again, just those types of diseases that's hard. But I also noticed in the Spanish population, the men as well, there's a lot of them, diabetes, they don't show. They show up for the first visit and we tell them this is what you need to do. We give them medicine and we don't see them for 2 years. And then it gets worse. And then they come back and they want us to treat them. I mean, by this time, they have foot amputations, their eyesight is going bad, so it gets really progressively bad really quickly. So I don't know, Dr. Mark, you tell me on what we should do. I don't know.
Yeah, there's an interesting question in the chat, that could kind of deal with either any of the things we've been talking about, but I think it's especially relevant to mental health. So here it is: language barriers, but also cultural understanding is crucial. Is there any initiative existing to reduce the brain waste and facilitate the recognition of migrant health professionals to work with their communities in the U.S.? And I think the thrust of it is we probably do have a lot of practitioners who are not just bilingual, but also kind of the place, where some of these immigrants are coming from, and maybe don't get the recognition that they deserve. Anybody come to mind?
I mean, our mental health person that we have here the days I work is a Spanish speaking person from, I'm not sure where she's from, but she's from Colombia, Olga's telling me. So yeah, she is really good at interacting with patients, seeing where they're from. And of course, the kids often adapt a lot quicker than the parents do. So she can kind of understand that dynamic also.
Great, thank you. So my next question has to do with COVID-19, and we could spend an hour each, kind of talking about this, but we'd really like to know, how has the COVID-19 pandemic complicated your organization's mission? In 30 minutes or less. Laura, why don't you start?
Sure. When the COVID pandemic started, I was still working for IRC, and my job typically involved traveling quite a bit. And initially, we pretty much halted a lot of travel. We had to put in place a lot of different policies. Fortunately, based on our experience with Ebola, we had a lot of staff who are quite experienced with dealing with outbreaks. So quickly put in a lot of criteria for deciding, who could travel, when could people travel. But we really were on the more conservative side in the beginning. So we really shut down travel. We shut down a lot of offices, which was quite challenging, it was fine perhaps in Washington, D.C. or New York, but in other places, people didn't always have the means to be working from home. So we had to figure out how to help people work from home, have better internet. Eventually in a lot of our country offices, things started opening up. People were back in the office a lot sooner than we were in the US, just because people either wanted or needed to be back in the office to actually get their work done. But it did slow down activities for quite some time. We obviously adapted and learned how to do a lot of things virtually and develop proposals and plan workshops online. But it did have an impact when there's certain things that really need to happen in person and that are quite challenging to do remotely. So when we were able to start opening up travel again, that really helped. But for a little while, only our emergency team was traveling. No one else was traveling for a bit. Here at DuPont Clinic, the clinic stayed open the entire time. But we're still masking in the clinic all the time. So it changed sort of how we operate a bit. But people didn't stop getting pregnant and needing abortions. So activities continued here.
Thanks, Laura. Jeremy, so the pandemic must have really curtailed the travel of both you and your colleagues, but I can imagine it also really made life really difficult for a lot of the detainees, that you're working with too. Tell us a little bit about your experience.
Yeah, I mean, it really changed everything, right? So I think first off, from a policy perspective, one of the things that the U.S. did was implement something called Title 42, and Title 42 is an ostensible health order that essentially says the border is closed. We can expel anyone we want. We could shut down the borders. We could shut down everything in the name of kind of preventing the spread of communicable diseases. Here we are, 2.5 years afterwards, Title 42 is still in place. The government has expelled, it's not people, but they've done over 2 million expulsions, right? And so, as our current law stands, there is the right to seek asylum in the U.S. has been effectively suspended. This has created tons of, as I said, camps and just hundreds of thousands of people along the border who are just waiting for things to open up and waiting for this public health emergency to be lifted. So I mean, it's just thrown a complete wrench, and it's like when you have a government that does not love the asylum process, the process for people to come into the United States in the first place, they're able to weaponize this. They're able to weaponize this process, a public health emergency, to essentially not do the stuff that they didn't want to do in the first place.
Yeah, I didn't thought about it until you brought it up, but in a sense, the pandemic made their job easier, where they've got kind of a ironclad, ready-made excuse, that you can't question anything that we do because we're trying to stop the spread of disease.
They love it. I mean, no masks on airplanes, airports. Everything else has been lifted, but for some reason, the restriction on migration is still in place. In detention centers, I had to drop everything. We dropped everything because people are held in rooms of 100 people who are sleeping all within 10 to 20 feet of each other. And so a lot of those people had comorbidities that placed them at high risk. And so and ICE was not trying to let those people out. That there was a lot of kind of COVID denialism going on. And so we had to file multiple lawsuits in order to get them to even consider people release. And
Wow.
so.
Olga, how about you and Mark in the clinic that you're working in? What was some of the big impacts, or what were some of the principal ways that COVID-19 got in the way of you delivering your services to, in particular, immigrant families?
You had kids just adapting to our schools, and they had to do virtual schools for like the first year. Then when they went back, if they sneezed, they'd have to come in and get a COVID test in order to go back to school. There was a lot of that. And then we saw some delayed diagnoses. I had a kid with kidney cancer that really kind of delayed coming in because she was afraid to come into the clinic to get checked. So the same things you saw across the healthcare system.
Anything to add? I've actually worked with you guys quite a bit during the COVID pandemic, and I know you've been struggling like anybody else. Any kind of generalizations or insights you'd like to share?
I think for us, just having to go into telehealth, everything was telehealth. I think when COVID started in March, it was telehealth for almost a year. And so that was hard because patients just wanted to come in. They wanted the providers to actually touch them and, check my heart, check my lung. I want you to check everything. They didn't want anything telehealth. That was really hard.
Yeah. So Omar's actually in the room with me with kind of one of those canes where they kind of take people off the stage, in the old days. And that's going to happen in a few minutes. But in the few minutes that we have, why don't you start with the last question? So if Papa Santa Claus or somebody kind of came and gave you a large grant, and wanted you to kind of, do something that would improve the health of, it could be the Vietnamese or the Latino immigrants that your clinic serves. Where do you think you would invest that? What would you do?
Oh boy, that's like the big unicorn, huh?
Yeah.
That wasn't the question that you proposed earlier, Mark. I had some. Yeah. I think for me, just if I could use that money, I want to be able to hire as many bilingual providers as possible wherever these providers are, because it's so hard for me to find bilingual providers. Like up until today, we're still looking for bilingual providers, Spanish or Vietnamese. I'd love to build another health center to service more community members. I'd like to, I guess, have somebody in legislation change the legislation where it's mandated right now, I think in the state of Louisiana, that anybody who has not been living in the state for more than 5 years is not able to access, services, is not able to, I'm sorry, not services, but Medicare, Medicaid, just, those types of services, someone up there to work on that.
That's good.
Yeah.
I really like your idea about getting more bilingual and kind of bicultural providers, maybe some training programs, to kind of, subsidize some of the educational costs, for Vietnamese speaking or Spanish speaking, or I don't know, other language, where there's a deficit, of providers. Jeremy, how about you? What's the low-hanging fruit from your point of view? You've got a big pot of money to kind of help the immigrants that are kind of, your constituency. What would you do?
Yeah, so there is no low-hanging fruit, but I suppose I think something that's already been done. In fact, like I think a lot of the students and recent graduates from Tulane have done a very great job of this. Is that like the medical profession, I think, needs to organize and like get out this message that like a detention center and a camp along the border, a refugee camp along the border that's ad hoc, not administered by the government, is no place to be healthy, right? So I think folks need to organize to put pressure on whatever decision makers that like okay, the best thing we can do for health is not use immigration detention and not have the border shut down. I think in general, in like my day-to-day life, we work with a lot of people who have had various things happen to them. So the case I'm working on next is a man who died in detention because he didn't receive medical care when he was getting a heart attack, right? And so we always need. I'm always actually my former roommate is a Tulane grad, so I'm just texting him all the time about like, all right, so like how does this concept with the heart work? What is a person supposed to do in this situation when this happens? But like having a group of doctors who can do evaluations, look over records, who can advocate for like doctor to doctor or nurse to nurse for people in detention centers. I think having those people kind of like on call and ready and willing to help, I think would be super helpful.
Fantastic, thank you. Laura, how about you? And you can wear your DuPont Clinic hat or your IRC hat.
Sure. From the DuPont Clinic perspective, I would love to lift the abortion ban in Louisiana, because people should be able to get healthcare where they live, and they shouldn't have to be traveling to Washington, D.C. And we've seen patients from Louisiana. So I would say that one. I think from my perspective, when I worked with IRC on the resettlement side, we responded to the Afghan response. So when all the Afghan refugees were brought to the US, we were supporting them on military bases. But sort of what we heard was, once they were off the military bases, being resettled in the communities, there were a lot of challenges. I mean, even though they had access to a lot more services than a lot of other immigrants would have had, it was still quite challenging because of language barriers, mental health issues, and just not knowing where to go to access healthcare.
Great, thank you. Mark, Olga, you get the last word. I mean, where are there opportunities? Where are the best opportunities for improving the health of immigrants, in particular the immigrant families that you see in your clinic?
I'll be brief and pass to Olga. I would just say early childhood development is difficult with all kids, but kids with autism, speech delays, things like that, when they immigrate here, it's just really difficult for them. So more services in that area. And I'll pass to Olga with prenatal care.
Thank you, Dr. Del Corso. In my case, I would love to be able to help those moms that are in situations such as harassment, or they have been sexually abused in the past. For instance, I have a patient right now that she is literally been terrorized for a year and a half. And she's afraid to go to the police. And only if I would have a place to take this patient, her child, and her now husband, So for me, that would be it. Be able to help this woman, that they are afraid. They don't want to go to the police or file like a police report simply because they really think they are going to get deported.
Yep, really, really difficult, really complicated. Thank you, Olga. Well, I think it's about all the time we have. Thanks so much to my panelists. As an academic, I love talking with people who are actually working with real live immigrants in the real world, and I learned a ton, and I'm sure that our viewers did too. You're all very successful, very busy professionals, and I'm very grateful that you took time out of your day to talk to us about the work that you do. So thank you very much. I'm going to hand it back to Omar.
Thank you.
Karen, sorry.
No problem, Mark. Thank you, everyone on the panel. I learned a lot, and I'm really grateful for everyone here. We have some questions referring to migrants who are healthcare professionals. If one person could answer the question about maybe how they can be involved, people who are immigrants who are healthcare professionals, how they can be involved, like maybe in 30 seconds.
Like in a volunteer capacity, you think that's the source of it?
I'm not sure if anyone on maybe the panel might be able to answer. I'm not sure.
I mean, I can comment that. Sorry, go ahead.
Laura, please.
No, I was just going to say that one of the biggest challenges with that is the licensing, right? That regardless of what kind of healthcare professional you are, if you're a licensed personnel, you have to get licensed in the US, which even for people in the US is quite a tedious process to get licensed. So for foreign professionals, it's not always so easy. So there could be things that could be done to try to facilitate that process, perhaps.
Okay, thanks. Yeah, so volunteering, like Mark said. Yeah, anything else that I'm missing before
I mean, we have a number of people that were trained in other countries, and here, they might not be licensed, so they work in other roles, which is which is very helpful. But yeah, the licensing, usually they have to do another residency and that kind of thing. But the nurses and the medical assistants, we have many from other places.
Okay. So yeah, yet another barrier that we have to work around and work toward eliminating on our journey toward health equity, particularly for this topic. So really, thank you everyone for participating as panelists. Thank you, audience, for participating as well. I really hope that you found this conversation illuminating. I definitely did, and that you can join us for our upcoming activities. So I want you to please mark your calendars for December 4th through the 6th for the 2022 Partners for Advancing Health Equity Summit, which is themed on the front lines of equity and justice. Registration is free, and we hope to host you during the summit that will feature interesting and engaging sessions led by multi-sector thought leaders, while we'll also provide opportunities for all to learn collaboratively and move the needle forward towards health equity. For those who are able to visit us, we will provide plenty of activities for you to get to know the city of New Orleans and its culture. And for those who are unable to visit us, you can still attend all sessions virtually. Also, if you haven't already become a member, please consider joining us to stay on top of the latest initiatives, activities, and resources produced by the P4HE Collaborative. And staying connected is very important, and it's a great way for you to be a part of these conversations. So please visit our website for information on P4HE and upcoming events, how to become a member, and follow us on social media. And with that, I want to say thank you for joining us and looking forward to hosting you in our upcoming events.